Dr. Khasne has. So, without further ado, she is the head of the Department of Critical Care Medicine at SMDP Institute of Medical Sciences and Research Center from Nasik. Welcome, Dr. Ruchira. Over to you.
Without much wasting time, we will move ahead with the goal-directed resuscitation. So since morning, we learned a lot about resuscitation or how to give fluids or when to start vasopressors and all. So now I'm going to introduce you the concept of deresuscitation. So this 4 Ds of fluid therapy, which was introduced by Melbourne, which we know everyone knows regarding the drug, dosing, duration, and de-escalation. So, in short, de-escalation is the similar way de-resuscitation. This de-resuscitation was introduced by Melbourne, and he wanted to convey that, of course, the fluids are necessary when the patient is into a septic shock, because in that phase, patient is in vasodilatation, hypovolemia, so definitely in that phase, fluids are important. This is a ebb phase. Normally, this ebb phase is transgressed into a flow phase, and the body tries to dispose of the accumulated fluid which is accumulated in the interstitial space. But in some cases, this transgression is not possible and leads to interstitial edema. So, might be in that stage, we might have to remove the fluid actively. So, for that, in initial stage itself, if we are little moderate on the fluids and if that is not sufficient, then we may remove the fluid actively, is the concept of deresuscitation. This concept of dynamics of fluid therapy was introduced by Melbourne, which is everyone knows, that is ROSE, ROSE. So R is a resuscitation, as I told you, which lasts for initial minutes or few hours. The initial insult is the inflammation, where we do a early goal directed fluid management, and we try to keep the patient in a positive balance and salvage the patient. Once the patient enters into optimization phase, which usually lasts for hours, and the ischemia and the reperfusion is the major insults, we primarily support the organ, and we should try to keep the patient in a neutral balance in this stage and rescue the organ. Once this stage is over and patient enters into a stabilization phase, again our main aim is to support the organ and try to keep the neutral balance rather than overloading the fluid, because the patient is now has been stabilized. And now the last stage is the stage of deresuscitation, where there is still some amount of evidence of a global inflammatory capillary permeability, which can cause fluid accumulation. And if we are able to identify this stage, then we should actively remove the fluid. So there has to be some parameters, because it is very easy to tell ROSE, but practically we should be able to identify in which stage my patient right now is. There are few studies, majority are retrospective studies on deresuscitation. So this study was in 2018. Basically, they observed that whatever the ways we resuscitate the patient, majority times only for the resuscitation, only 6 to 7% of the fluid is given to the patient, and medication maintenance and the IV bolus contributes lot of IV fluids, and that lead to a positive balance. So, if those who are positive, if we actively de-resuscitate, then they observe there was an improvement in the outcome, shorter duration of the mechanical ventilation and length of ICU stay without much affecting the AKI staging. And in contrast, those who were positive in positive balance, they had a longer ICU stay. So, aim is to minimize the fluid balance by mainly cutting down the maintenance IV fluids, diluents for the sake of giving antibiotics, analgesics. These are the main contributors to keep the patient in a positive balance rather than resuscitation. So, always ask these questions: when I should start the fluid, when to stop the fluid, when we should start active fluid removal, and simultaneously, I'm not only saying that deresuscitation is good, but we should know when to stop active fluid removal. That is also very important. As I said that hypovolemia is bad in initial stages of sepsis, simultaneously hypervolemia is also bad. And in initial stages, there are convective problems. So yes, we need to give fluids, but once the normovolemia is achieved or a patient has entered into a optimization or a stabilization stage, then if we keep on resuscitating such patient, then that may lead to hypervolemia and cause diffusion problems. These diffusion problems are going to affect every organ of the body. In lungs, diffusion pulmonary edema will lead to delay in the mechanical ventilation. In abdomen, increase abdominal pressure. It will affect the wound healing. It will impair the renal blood flow. It will cause a myocardial edema causing systolic and diastolic dysfunction. So every organ is going to get affected by this positive balance. This is a retrospective study. It was a actually old study which they said a PAL treatment protocol, which particularly they selected the cases of intra-abdominal hypertension along with the ARDS, and they introduced the concept of P stands for high PEEP. The high PEEP means the PEEP which was equal to the intra-abdominal pressure, along with small volume of resuscitation with 20% albumin, that is A, and L is Lasix, that is diuretic. So they categorize the patient, and in the PAL group, they could achieve a good negative balance. There was a reduction in extravascular lung water. There was a reduction in intra-abdominal pressure along with the reduced ICU days, ventilatory days, and mortality as well, without compromising the cardiovascular and the renal function in the PAL group. But this was a retrospective study. Second is another study is FFAKI trial, but this was a low powered trial. But what they did is they forcefully removed the fluid, and they compared this forced fluid removal versus the standard care, and they observed that yes, they could achieve a good negative balance without causing much adverse effects. But as there was a very low recruitment in this trial, so it was not that powered. Another protocol was active diuresis for the sake of resuscitation was implemented in one of the studies which was published in 2020. They observed that there was a reduction in mortality in ICU free days, but it was associated with some electrolyte imbalance. So we don't know whether this deresuscitation, how of course it is important, but there might be some side effects of deresuscitation, and still we don't know whether it really cause benefit or not, or maybe while over aggressive deresuscitation we should not cause other organ failure, because majority of the studies are retrospective or case based. This is a recently published study in 2021 radar trial, which was a randomized control trial. They compared a conservative or deresuscitation versus a usual care, and they could of course achieve a good negative balance in the deresuscitation group, but they could they were failed to conclude because there were baseline imbalances between the groups, and there was lack of statistical power. So up till now, whatever studies we have, they were less powered, and so we need further good randomized controlled trials for its benefit. Now if you see this graph, you can see ROSE, as I explained you, resuscitation, optimization, stabilization, and E is deresuscitation. So the 4 hits are compared. So deresuscitation is hit 3. But if we over enthusiastically deresuscitate such patient, then there is a chance that patient may enter into a hit 4 stage. And if you compare this hit 3 and hit 4 with the organ failure, then there are high chances of organ failure if the patient enters into a hit 4 stage. So you have to be very, very careful when you initiate deresuscitation. So of course we know that dry lungs are happy lung, but as I said, that because of over enthusiastic deresuscitation, we can enter into HIT 4. So there should be some parameters based on that we should initiate the deresuscitation as well as we should stop the deresuscitation. So parameters like PF ratio, extravascular lung volume, like trend of these parameters, intra-abdominal pressures, and nowadays we are into the era of lung ultrasound. So serial evaluation of the POCUS. So these are these parameters might give you some objective criterias when to start active deresuscitation and when to stop it as well. So this is a flow chart. For example, if my patient is obviously into evidence of inadequate tissue perfusion, of course, then that stage patient needs fluid and we will correct the hypovolemia. If initial resuscitation is over now, then always look for that whether this patient is into obvious accumulated positive fluid balance, which we can do by POCUS. There is some cobblestone kind of appearance if you do a bedside skin ultrasound. And if you can see that there is a positive accumulated fluid balance, then there are various parameters which are described in POCUS. What are those parameters? For example, if the IVC is more than 2 centimeters without any variability, or we are doing a velocity time integral and there is no variability, or if we are doing LVOT VTI with PLR and there is no much improvement in the VTI after PLR, or there is associated diastolic dysfunction. If these parameters are supported by association of new onset of B lines on lung ultrasound, or if there is a RV dysfunction or extended venous ultrasound is showing venous congestion, these are the few parameters. Based on that, with the support of new onset B lines or the B line score is increasing, then you should actively deresuscitate such patient. And if the patient is hemodynamically unstable, then one should start the vasopressors instead of giving further amount of fluid. So one should know the concept of, as we know, antibiotic stewardship. Of course, fluid stewardship is also important. So there should be a fluid team with fluid stewards giving right fluid, right dose, right patient and right time. And the fluid stewardship is series of coordinated interventions to select the optimum fluid, dose, duration of the therapy that results in best clinical outcome, prevention of the adverse effects and cost reduction. So I will end up my presentation by few important take-home messages. Always remember 4 Ds of fluid therapy. Its analogy is similar to antibiotic stewardship. The concept of Rose model, which is which introduce you to a dynamic approach to the fluid therapy. Always remember the stages of Rose. Each phase requires a different therapeutic attitude regarding the fluid administration. Use the fluid for resuscitation, but it should be used wisely. Prefer use of vasopressors. Do not prescribe the fluids routinely as a maintenance fluids if they are not needed. And POCUS will definitely help you to guide when to start the deresuscitation actively and even when to stop deresuscitation. So are you following fluid stewardship at your center? Thank you.
Thank you very much, Doctor. You have given us 1 minute to spare. Wonderful.
Ma'am.
Thank you.
Actually, I wanted to ask if there is a evidence of any tissue edema, where do we have to look for? Are there specific points that where we have to look for the tissue edema, like in the thighs or in the abdomen, or where should we look it for?
To my knowledge, there are no specific areas are described at least up till now in the literature.
Okay.
If somebody has to comment on it, I'm welcome.
And ma'am, regarding if a patient is coming with anasaka, like in cardiac failure or renal failure, liver failure, does it stand true in all those cases also?
Yeah, obviously. So there has to be some always a clinical correlation. These are the objective parameters, the way what I described in the POCUS. But of course, we are going to correlate these parameters along with the clinical examination.
Thank you, ma'am.
Thank you, doctor. Thank you.
Thank you, ma'am.